Welcome to this very uh, important discussion for today evening on our UROCONNECT program. Today's webinar topic is on management of IVC thrombus in RCC patients, the practical aspects of it. It's a very intriguing topic that will be discussed today. It's a situation that we encounter quite a bit in our daily practice in RCC patients, but till now there are many doubts regarding in what all to manage and how to manage the different kinds of situations of IVC thrombus. So we'll be enlightened on those facts. For that, tonight we have Professor Rishi Nayyar from AIIMS Delhi to discuss upon that topic. So welcome, Dr. Nayyar.
Thank you, Dr. Sayak, and I am grateful to the entire Bengal Urological Society for having me in this program. Am I audible properly?
Yes, sir. Yes.
So let me share the screen. Visible now?
Yes, sir. Visible, sir.
Full screen?
Right, sir. Full screen.
Okay. So again, thanks for having me in this program, which the Bengal Urology Society is hosting especially for the postgraduates benefit, and the topics they are choosing are with regards to their benefit for the exam purposes, as well as for understanding of the aspects of urology which remain relatively uncovered during their 3-year course. So today we are talking about the management of IVC thrombus in RCC. I would be talking basically about only the practical aspects, but just to give you a brief overview, although now RCC is now mostly diagnosed incidentally up to 60%, in fact a little bit more, 65%, 70% are diagnosed as small renal masses these days. But if you look at the same time, this venous involvement has not decreased over the years. Still about 25 to 30% of the cases do present as metastatic RCC at presentation. So in those terms, venous involvement is relatively less. Metastatic RCC is more common that we see. But one should see that whenever venous involvement is there, about 85 to 90% of the patients of these venous involvement are actually without systemic metastasis. And this is a surgically curable disease. Metastatic RCC, as you know, has a very grave prognosis. It is one of the most dangerous urological malignancies, with a overall 5-year survival to the tune of just about 25 to 30%, in fact, even a little less. And 1-year survival is about 50%. So metastatic RCC is a aggressive disease, but the venous involvement is a surgically curable disease. And even in 3B and 3C IVC thrombus tumors, the 5-year survivals achievable by surgical means are high, up to the tune of up to 70%. So the survival benefit is there for these IVC thrombus patients, and they should not be just regarded as, although they are locally advanced, they are curable to quite an extent. This is the level of thrombus and the incidence that we see for these thrombi. Fortunately, most of the thrombi are lower level thrombi, 0, 1, 2, and up to 3. 3 means up to the level of hepatic veins and thereabouts. And above the diaphragm are just about 5% of all RCCs presenting with the IVC thrombus. So above diaphragm are rare, but about 20 to 25% are IVC thrombi, which are retrohepatic and suprahepatic levels. The lower levels can be managed much easily. Whenever you get a case of RCC in the exams, the preoperative workup is the important issue that is going to be discussed during the exams. And during the preoperative workup, you must be able to tell the cross-sectional imaging of the chest, abdomen, and pelvis and read it properly, because these CT scans are to be read primarily by the urologist. One cannot depend upon the reports in this IVC thrombectomy patients, because even radiologists are not well versed in telling you and reading these CTs and MRIs by themselves. And if you are operating on such patients, you must be sure that you are operating with a CT or MRI that is within 1 week of this RCC, of the surgical date. But generally what we do is we repeat, even if we have a 1 week CT or MRI, we would repeat Doppler, at least a Doppler ultrasound just a day prior to operating these cases, because we have seen cases within a week, these level of thrombi extension can extend significantly, and the surgical entire work plan can change 1 day prior to the surgery itself. So how to read the CT or MRI in these particular patients? First things first, there is not much of a difference in terms of what a MRI can tell you or what a CECT can tell you in terms of the perirenal involvement and the lymph node metastasis. By that, I mean the identification of lymph nodes. If you are concerned about the characterization of the lymph nodes, meaning thereby you want whether this particular lymph node, which is more than a centimeter, is really metastatic or not, then CECT holds an edge over a MRI. And if you are concerned more about the extrafascial tumor spread, like involvement of the duodenum, involvement of uh, the pancreas or the liver, then in those terms, MRI is superior. But overall, generally, CECT suffices for most of the cases. And it's only in cases like renal failure or pregnancy that MRI can be considered as the first choice. Otherwise, CECT is generally sufficient. But when you have any doubts, when you want some clarity, then you can have both. In fact, if you have a CT done earlier, then you can repeat a MRI to get clarity on the issues that I just talked about. So how to read or present a CT in the during the examinations? So in a case of RCC, the most important film or phase of the CT that is the venous phase. So whenever you are given a plate of CT, you must first see the phase of CT and pick up the venous phase out of those plates, and then start looking on that plate. Uh, the arterial phase and the excretory phase are not that important, uh, but they have their own relevance. But you should focus primarily on the venous phase. By venous phase, I mean, if you are not able to identify the contrast in the veins or artery, just look at the kidney and see if the corticomedullary differentiation you can appreciate, then that corresponds to the venous phase most of the times. So pick up a film which shows the corticomedullary differentiation on the normal side. Now, then the second thing is to check the extent of the CT plate that you have. Here we have the right from the level of mid of the heart to the upper abdomen. And so this CT covers the upper abdomen primarily. Then we come to the pathology proper, the RCC itself, and the site, which pole of the kidney is involved, the size, heterogeneity, all these are to be mentioned. Necrosis, and if there is any bleed or not, that has to be mentioned. And then the adjacent organ involvement. In such cases where the IVC is also involved or where the tumor is large, you must carefully look at these organs independently by yourselves, like the liver, adrenal, duodenum, and colon on the right side, and similarly the spleen, pancreas, adrenal, and the colon on the left side. So you must look carefully. Like in this case, this is a right-sided tumor. You should look for the duodenum. How you look for the duodenum? See the contrast, oral contrast in the stomach. Just keep following that, and this contrast would ultimately lead you to the duodenum. This actually is the colonic contrast Here we do not have the duodenal contrast in this particular film. The duodenum lies here. Anyhow, so you will have to see the separate films, but you must comment upon these organs. And if you are able to tell the at least the issues, like here you can see that you are not able to clearly make out the plane between the liver and the duodenum. So there may be a possibility of the involvement of the liver, the segment 8 of the liver at this point. So therefore, if you are in doubt, then you can get a MRI to just clarify this particular issue more. But otherwise, most of the time what happens is it is just abutting, and the actual invasion is seen in just about 5 to 10% of the cases. Then we come to the extension, whether there is a tumor thrombus or not. How do you judge that? We'll come to it in the next slide, and then the METs has to be told. First was the local involvement, and then the second, the METs. The METs can again occur in the liver separately, the opposite adrenal, the same side adrenal, the lymph nodes. Where do you see the lymph nodes? The lymph nodes are to be seen again for the left side, primarily on the para-aortic region, and for the right side, the paracaval and the interaortocaval region. So here you will look for the enlarged lymph nodes. And ultimately, after the end, you should make out clinical staging or according to the TNM stage. If you give this much of information on CT, you are able to judge what all factors which would be important for the subsequent management of the patient, both in terms of surgically as well as the non-surgical management. So now let's come to the thrombus proper. How do you tell what are the issues for the thrombus? Whenever you find that there is a thrombus, the first thing to judge is what is the level of the thrombus. So you have to start from either from below or from above, wherever you can see the contrast in the IVC. From there you can start following. Like in this case, if you see below, there is some contrast in the aorta still, but the contrast cannot be seen in the adjacent IVC. So let's start from this IVC, the cranial part of IVC, where we know that this is normal, and we can keep following it. And if this is the level of the hepatic veins, you can see. Normally, what happens is the right and the middle hepatic vein would join together, and the left hepatic vein would drain separately into the IVC. In this particular case, it seems to be anomalous drainage, where the middle and the left hepatic vein are
তাহলে ওষুধ খেয়ে নাও,
they are joining.
খেয়েছো তো
So they are
খাবো,
joining
কাল রাতে
together.
খেয়েছো, প্যারাসিটামল তো খেয়েছো, প্যারাসিটামল কিছু হচ্ছে না।
Yeah, I believe some people should have to put their mic on mute. It's disturbing.
So this hepatic veins are draining here. So this level is important, where the hepatic veins are draining to the IVC. At this particular point, there is complete flow in the IVC that you can see. So this is this part of IVC is normal, and therefore we know that it is a retrohepatic. It is not a suprahepatic thrombus, and we keep following this. At this point, you see that there is a filling defect in the central part of the IVC. There is flow and contrast can be seen in the peripheral parts of the IVC. And if we keep on going below, you see that this thrombus is still there. The thrombus still there, thrombus still there with some partial flow still there around the thrombus. From here on, if you see that the thrombus has almost occupied the entire lumen of the IVC, with no specific contrast and flow seen around the thrombus. So this is completely blocking the IVC. Here again, you can see now the IVC has actually started engorging and increasing in diameter, and this is the thrombus. And at this point, we see that there is a continuity of the thrombus along with this tumor. So this is probably the renal vein area. Now we are coming, and here it is completely there. Now from here on, you see that this tumor thrombus is present in the IVC, and the tumor mass is separated. So completely occluded the tumor thrombus. Here also you can see the vascularization inside the thrombus. And at this point, this has almost completely merged. So here we are not able to differentiate whether the tumor and the IVC wall can be separated or not. So in this particular case, there may be IVC wall involvement. In this situation, even MRI would not be able to give clinically meaningful answers, even if we can do it. But when there is tumor on both sides, it is very difficult to appreciate whether the thin wall of IVC would really be involved or not. And in such a situation, we should really be prepared for the replacement of the IVC wall with either with a patch, or if the whole of the wall is involved, then with the graft tube. And so we can continue to follow. But if you see, the thrombus was enhancing till this level, enhancing this level. But below this level, it is not enhancing. But and there is no contrast in the IVC as well. So IVC is completely blocked. So we can say that there is a thrombus in the IVC. This is bland thrombus, and this enhancing thrombus was the tumor thrombus. So inferiorly, this is a bland thrombus. This way we can keep following and tell about the characteristics of the IVC thrombus. Like we keep on following. From here, the thrombus starts, and the thrombus is there continuously till this point. Till this point is the tumor thrombus, but even below there is a bland thrombus which is continuing till the cuts that we have. And as I told, the hepatic vein confluence you must identify. So when we know that the thrombus is below, if we see this is about 5 mm cut, so 5 mm and 1 centimeter. So this thrombus is reaching up to about 1 centimeter to the hepatic vein confluence. So this is a retrohepatic type of thrombus, the highest level. Then we need to identify whether there are collaterals or not. This flow, as I told you, is important to identify, because here the thrombus would not be attached to the IVC wall. So when we are manipulating the thrombus lower down, this thrombus has a tendency to get embolized. So a thrombus which is distending the IVC and is a tumor thrombus is generally not that friable. But a thrombus which is floating free in the IVC lumen, that can actually break down during the IVC dissection and manipulation. So in the upper part of this dissection, we have to be very careful during the dissection of IVC. Then the collaterals. What happens with this is blockage of the IVC. The venous flow starts flowing retrogradely, and there are collaterals present all in the retroperitoneum through the gonadal vein collaterals, and then through the phrenic vein collaterals. So all those venous channels open up and broaden up. They are actually venules which distend and seem like veins, but their walls are very thin. So they are prone to bleed during the surgery. So if we go like a standard nephrectomy and start operating either from the flank or even from the midline, and start operating on the lower pole of the kidney, and then pulling it up, trying to go towards the renal hilum, all that leads to is very, very significant bleeding, because there are collaterals here, and then there are arteriovenous shunting here within the tumor. So there is a massive flow through these veins. These veins do not bleed like veins. They bleed like sometimes like arteries. So the idea for any such radical nephrectomy is to go to the renal hilum first, and by renal hilum I mean to the arteries first. So for the right side, we can rather than go through dissecting the lower pole first, what you can do is go towards the left side, and just medial to the inferior mesenteric vein give a incision, and then go into the interaortic cable towards the right border of the aorta, and here identify the right renal artery. Like in this particular case, if we try to identify the renal artery, although this is a venous phase, we cannot be sure in this. but somewhere here, yes, this. You can see some contrast in the aorta, and there is one contrast-filled channel going towards the right side. So the reaching this artery would also be difficult in this case. But if you try to reach the artery from here, uh, by the time you reach the artery, the patient would have bled very significantly, and even before you reach the stage of thrombectomy, there is a possibility that the patient might have received 3-4 units of blood already and might be on inotrope. So that is not a good situation to have, because all these have an impact on the function of the opposite kidney also, which may go into AKI subsequently later on. So it is very, very important to reach the renal artery first without actually dissecting through these collaterals. So then coming to the rest of the preoperative workup, this was about how to present a CT and what are the important salient points, how to read that. But beyond the CT and MRI, there are other investigations that become important in these cases of IVC thrombus, uh, which are pulmonary evaluation and cardiac evaluation. Both of these are essential, particularly for those patients who are going to be put on cardiopulmonary bypass. And in those patients, even coronary angiography is to be done routinely, because most of these patients are old, and when the chest is being opened up, then if there is some narrowing of the coronary artery, or there is coexisting coronary artery disease, the revascularization of the heart and bypass CABG can be done in the same sitting. So in those cases, bypass is actually done first, and then you remove the thrombus. Doppler, as I told you, it is important to be done just 1 day prior. Most of the times, the distance can change. And then for the bland thrombus evaluation, one has to know the lower extent of the bland thrombus also. So let's come to the surgical aspect of it, the radical nephrectomy. The nephrectomy as such has, in these cases of IVC thrombus, is to be done with the idea of reaching the artery first. This can be done through the chevron incision or hockey stick incision, and if CABG is to be done, or the bypass is to be put, then long midline with sternotomy can be used. And in some cases, thoracoabdominal incision may be preferable. These are cases where the thrombus is extending till the level of hepatic veins. We may have to mobilize the liver completely, the right liver completely to the left side, so as to be able to access the posterior aspect of the retrohepatic IVC. So in those cases, thoracoabdominal approach may be useful, but this thoracoabdominal approach is used primarily for the right-sided tumors. For the left-sided tumors, IVC thrombectomy from the left becomes very difficult through this approach. So most of the procedures are done either through the chevron or the long midline with sternotomy. The concerns for patients with IVC thrombectomy, I've already told you, these are two, that they are collaterals, and early arterial control has to be established, whether it is right or left. On the right side, we can always go to the interior aortocaval approach, but for the left renal artery, sometimes it becomes difficult because the left renal artery would be lying behind the dilated left renal vein, and then reaching till that point to the artery again, we will have to go through all these collaterals, again risking the bleeding. So sometimes in left renal tumors with IVC thrombus, we may resort to doing a preoperative arterial embolization, so that at least venous bleeding would be taken care of till the time we are able to reach the artery. So as I said, for the left side tumors, you start with this Mattox maneuver, mobilize the entire gut towards the right, and then follow the ureter along the left border of the aorta till you identify the left renal artery. And for the right side, the first incision is to be given is just medial to the inferior mesenteric vein, or to the right of the this ligament of Treats. And then go along the right border of the aorta to identify the the right renal artery. So this is a small video how to approach these cases, how to start. A chevron incision is given in this case, and then just medial. This is the inferior mesenteric vein. The entire gut is kept on to the left side, and the small window is created on the mesentery. And underneath this inferior mesenteric vein, one has to identify the left renal vein. And behind this left renal vein would be the right renal artery. To reach that, we have to ligate all these lymphatics on the lateral border of the aorta. So now you can see this is the aorta, and it is always good to ligate all these lymphatics because of the venous congestion. Even these lymphatics are congested, and sometimes they can also be confused with veins. So this is the right renal artery behind the right renal vein, and this is ligated. So at least two ligatures should be placed on the aortic side, and towards the tumor side also one ligature should be placed. And if you cut the renal artery in between these, what it does it releases the tumor a little bit from its hilum, and the dissection of the rest of the kidney also becomes a little bit easier. So you should also cut the artery at this level itself. Now coming to the thrombectomy part, the rest of the kidney is to be moved. Once the artery is done, then the rest of the kidney is to be mobilized as for any other nephrectomy. And ultimately, finally, what you are left with is the kidney hanging on to the IVC with the intact renal vein. All this mobilization has to be done very carefully, not to mobilize the tumor so much that the thrombus to fracture and cause embolus. The classification of the thrombus is clinically important. We used to follow this Mayo Clinic classifications, but the practical clinical classifies this venous thrombus into 6 levels. Within the renal vein is generally manageable very easily as for any other radical nephrectomy. Then infrahepatic means thrombus is below the lower border of the liver, and you do not have to mobilize the IVC into the liver. As the IVC enters into the liver, if the thrombus reaches beyond that point, then it should be called as retrohepatic thrombus. And a retrohepatic thrombus would be level 1 if it is more than 2 centimeter from the hepatic vein confluence, and if it is less than 2 centimeter to that hepatic vein confluence, that should be classified as level 2. Why this is important, I will come to. This is surgically important. This is not important with respect to the prognosis of the patient. Prognosis of all these thrombi is, as I said, are clubbed together as T3B level, below the diaphragm level. And even suprahepatic level, if it is, can be below diaphragm. And then there is suprahepatic above the diaphragm and intracardiac levels. Now, these are practical levels with respect to the surgery and the maneuvers that we do for removing this thrombus. So this is renal vein. This is infrahepatic. This would remain infrahepatic till this level where you do not have to mobilize the IVC within the liver. Then retrohepatic IVC, level 1 when it is more than 2 centimeter beyond this hepatic vein confluence. Retrohepatic 2 when this reaches within 2 centimeter or just above till level of this hepatic vein confluence. Then suprahepatic level when it reaches above the level of the upper border of liver. This one may be able to get a control with below the diaphragm in such cases, or may require a control intrathoracic inferior vena cava. Here the control may be required. So the management of thrombi which are below infradiaphragm would be different from those which are above the diaphragm. And then the last level is the intracardiac. Even in intracardiac, the thrombus may remain within the right atrium only. Sometimes it grows or pouts into the right ventricle also. So for the level 1 thrombus, what is to be done is we have to apply the IVC clamp. Side clamp is to be applied. While applying the clamp, what is important is do not apply the clamp while keeping a traction on the tumor. Because what happens is if you try to apply the clamp very close nearby, and when the traction is there, then once the venotomy is given, then there is a tendency for the venous wall to retract back, and then there may be a significant bleed trying to work around those retracted walls. So therefore, mobilize the IVC completely. If there are some lumbar veins coming in between, you can ligate those, but always apply the clamp in a way that the tumor is not stretched, and you can occlude half the lumen of the IVC easily without causing blood pressure issues for the anesthetist or the patient. So once this clamp is applied, then the venotomy is to be given nearby the ostium. Again, do not
This
give
meeting is being recorded.
venotomy very close to the IVC wall. Keep 1 or 2 millimeter away on the renal vein if feasible. And venotomy is given like this throughout anterior wall first. Flush out the tumor towards the kidney, and then the posterior wall venotomy can be given in the same way. And then the IVC can be repaired with the 5-0 or 6-0 Prolene sutures. Then we come to the level 2 or the infrahepatic thrombi. In this, the mobilization of the IVC that would be required is much more than what can be managed with a side clamp. Here you will have to take control of the IVC circumferentially below the level of the thrombus. You have to take control of the opposite renal vein, and also the IVC above the level of the tumor thrombus. So while mobilizing all these, it is important that all the lumbar veins which are there from this level to this level are taken care of on both sides of the IVC. Because what will happen is even if you clamp here, and clamp here, those lumbar veins would still be draining. And once a venotomy or a cavotomy is done, then those lumbar veins will continue to pour blood into the IVC, and there would be significant blood loss in removal of this after removal of this thrombus while you are trying to close the cavotomy. So therefore, mobilize the IVC along with the lumbar veins, right from this level to this level. So all these veins must be ligated. And after that, once all this is done, apply the application of clamp has to be done in this particular sequence only. Do not apply the upper clamp first. Always apply the clamp on the side from which the blood is coming first. So first clamp is applied infrarenal, then the second clamp is applied on the opposite renal vein from where the blood is coming, and then at the end the clamp would be applied on the drainage side from where the blood is flushing out. So now this will isolate our segment of the IVC completely. So now once this is done, you give a cavotomy, like in this particular case. This is the opposite renal vein. This is the clamp which is applied below the thrombus. This is the clamp applied above the thrombus, and cavotomy is done. Tumor is on the right aspect. So the thrombus is flushed out. Make a cavotomy incision only from where you think, don't extend it too much. It should be just sufficient enough for the thrombus to come out easily. So once the thrombus comes out completely, then the cavotomy can be repaired with a standard 5 or 6 of Prolene. Single layer or 2 layer, all are good. And then the removal of these clamps is also in the same sequence in an inverse manner. So the first will remove the distalmost, which is the the highermost clamp, so that the blood starts draining. Then you will remove this number 2 clamp of the opposite renal vein, and then you will remove the inferiormost, which was applied first. So this sequence should remain the same in all cases. So this was the final specimen in this particular case. Now, retrohepatic IVC, when the thrombus extends above the level of the lower border of the liver, and if the thrombus is just about 1 to 2 centimeter extending in the retrohepatic IVC, what can be done is we can mobilize the IVC from below only, like just identify the veins which are draining the caudate lobe of the liver here. Generally, there are 4 or 5 veins which directly drain the caudate lobe, and once they are taken care of, one can make a plane between the IVC and the adjacent liver parenchyma, and the IVC can be easily mobilized away from the liver parenchyma. And once that is done, then rest of the management would be similar to as we have done for a infrahepatic thrombus, because we are able to now apply the clamp on the suprahepatic IVC. And again, the application of the clamp would be in the same sequence. First, the infrarenal clamp, then the contrarenal renal vein clamp, and then the suprarenal infrahepatic vein clamp. So once this is done, make a cavotomy, remove the tumor thrombus, and once you have pulled it down, then you can even take your clamp lower down. You need not make a cavotomy right to the whole length of the isolated segment of IVC. Only cavotomy is done in the easily accessible part of the cava, where you would be able to do the repair easily. So make a cavotomy there, pull out the thrombus, and some plane can be made between the walls of the IVC and the thrombus using the right angle forceps or the fine artery forceps. Most of the time, these are tumor thrombus, so and they are not invading 80 to 85% of the time. So one is able to easily clean out the entire IVC. Now we come to the retrohepatic thrombus level 2, where it is reaching close to the hepatic vein level. In these cases, we are not able to mobilize the IVC from below the liver only. We have to mobilize the liver completely from the right side towards the left side, which is called as a piggyback mobilization of the liver, generally used for by the liver transplant surgeons. So here you will have to mobilize the right triangular ligament of the liver, the bare area of the liver, all the ligaments here on the right lobe and to some extent on the left lobe have to be cut, and the entire liver is mobilized towards the left side. And then the dissection of the IVC can be done from the posterior aspect. And here what becomes important is when we are going to apply the clamps, the first clamp would be the same, the second clamp would be the same. But now if we apply the clamp above this level of hepatic veins, this is going to, because the arterial flow into the liver is going to be intact. So therefore the liver is going to get very congested, and then there would be retrograde flow here through these hepatic veins into this IVC lower part. And when cavotomy is going to be done, there is going to be profuse bleeding. So therefore, when the clamp has to be applied above the level of hepatic veins, it is essential that we also isolate the porta hepatis, where the portal vein, hepatic artery, and common bile duct together are clamped with a Sateski clamp, so that the inflow into the liver is also blocked. And when we isolate this segment and make a cavotomy, the bleeding is not going to be there. And then finally, the fourth clamp is going to be above the level of the thrombus. This is the suprahepatic clamp, where you are going to mobilize the IVC above the level of the thrombus and above the level of the upper border of liver, below the diaphragm. So once this is done, you give a cavotomy. Once the thrombus has been retracted to some extent, you can reapply this clamp, because you have already mobilized this IVC also. So clamp can be applied here, and then the upper clamp can be removed. what happens now is you can now remove the OTA clamp. For the lever, we can keep it clamped safely, easily for 15 to 20 minutes, but even up to 30 minutes is okay. So generally for most of the tumors, we are able to clean the IVC in the lower part and pull down the thrombus. So once that is done, then within those 20 minutes, we can bring the clamp down so that we can do rest of the procedure without any pressure of the hepatic ischemia. So this is one such example, the left side tumor thrombus. Here the thrombus was also extending into the gonadal vein and going high up, right up to the the level of the hepatic veins. And this is the right side, similar kind of a tumor going till the hepatic veins level. Now we come to the suprahepatic thrombi levels. Once the thrombus reaches above the level of the hepatic veins, then it becomes a suprahepatic thrombus and above the level of the upper border of liver. If we can get some plane here below the diaphragm, then the dissection is going to proceed as we did for the previous description. But this plane is just about 5 mm to 8 mm, and not in all cases you will be able to get a clamp here. So therefore, the options that remain is going intrathoracic into the pericardium and then clamp the infrarenal IVC within the pericardium. So this would be a non-bypass technique where you are just making a sternotomy. The sternotomy in this case is going to be only the lower half sternotomy to just get access to the pericardium, and then we loop around the intracardiac inferior vena cava. So within the pericardium, we'll get the control. And without putting the patient on bypass, the rest of the procedure can be done as we had discussed for the previous level or the level 2 retrohepatic thrombus. Again, the Pringle, the clamp would be on the IVC on the opposite renal vein. Third clamp would be on the porta hepatis, which is the Pringle maneuver, and then fourth clamp would be in the intrapericardial IVC. This type of case can also be done on a cardiopulmonary bypass, and if it's done on a cardiopulmonary bypass, then most of the times they do not go to complete 18-degree hypothermia. Generally, these cases are manageable with just about 24 or 25 degrees centigrade hypothermia, and incomplete cardiac arrest is done. Some flow continues into the rest of the body also. So now coming to the highest level of tumor thrombus. In these cases, cardiopulmonary bypass is essential, and a complete deep hypothermic circulatory arrest is used in these cases. We go, the temperature of the patient is lowered till the level of 18 degrees centigrade, and at this level, almost nil flow is kept to the rest of the body. Just about say 40 to 50 ml cardiac output is maintained, and that is sufficient to maintain the perfusion of the tissues for some time. And we have about 15 to 20 minutes for each circulatory arrest cycle, where it can be done. The procedure, whatever we have to be done, can be done safely. Now, if this is not adherent and if the surgeons are confident that they would be able to complete the thrombus removal as well as the repair of the cavotomy within 20 minutes itself, then there is a way of doing a partial circulatory arrest, and the hypothermia is done only till 24 degrees. So in those, if you do the case using this particular technique, a safety valve that can be kept is just keep the aorta, the infradiaphragmatic aorta can be control can be kept, and in case if you are going beyond the time limits, you can clamp the aorta so that the blood flow to the upper half of the body can be maintained, whereas the blood flow to the lower half of the body would be kept clamped, and the bleeding would be less. It again gives about 15 to 20 minutes of safe time If we go beyond that, there would be too much of lactic acid and anaerobic perfusion of the lower half of the body, which is not good. So the safe way is to go till the 18 degrees Celsius with complete circulatory arrest. But if you are comfortable and you know that you would be easily able to remove, then even mild hypothermia and partial circulatory arrest technique can be used in some patients. Clamp sequence again remains the same, inferior renal clamp and then the opposite renal clamp. And because we are doing complete circulatory arrest and the perfusion as it is not going to be much, so therefore porta hepatis clamping is not required in this particular setting. The aortic clamp can be kept if you are using the mild hypothermia technique, but most of the cases are to be done under complete circulatory arrest using a bypass machine. So what happens in a bypass machine is that first we put the venous cannulas below the level of the thrombus. A venous cannula is put into the IVC to bring the blood coming from the lower half of the body to this bypass machine where the blood is going to be oxygenated. And similarly, a cannula is put into the superior vena cava within the pericardium. And from there also the blood comes into this machine, and then this pump circulates the oxygenated blood through the aorta where this cannula is put into the aorta, and then perfusion continues. Once the temperature of 18 degrees is achieved, then this pump is just pumping about 50 ml or 60 ml of blood per minute. So this is one such example of right RCC with the intracardiac thrombus. What is done is after doing the rest of the nephrectomy, as we have discussed, the kidney is now only hanging on the thrombus and cavotomy, and here the heart is opened up, the pericardium is opened up, the right atrium is open. And as you can see, the heart is not beating. This is complete circulatory arrest on the bypass machine. Heart actually, when once this hypothermia is reached, the heart goes into a state of flutter. It is not pumping anything. And once the thrombus is completely removed, you just sew the atrial walls, and then thrombectomy is completed. Time permitting, I will show you one more detailed video of intracardiac thrombus. Like this is one such case with a complete intracardiac thrombus. This is the thrombus, hugely dilated vein. With no blunt thrombus. So this is all tumor thrombus here and going till high level. So in such cases, the abdomen is opened with a midline incision. Because it is a right side tumor, will go medial to the inferior mesenteric artery just by the ligament of Treats. This is the DJ flexure. Identify the left renal vein and then follow the lateral border of aorta. So by palpation, you can feel the aortic border and then ligate all these lymphatics. Once you identify the left renal vein, then keep moving underneath that. Ultimately, just below the renal vein, you will see the right side renal artery behind this renal vein. So loop it, ligate it properly, and cut it. Although this may seem like a daunting task, but this step is very, very important to to minimize the blood loss that the patient is going to have and to prevent AKIs subsequently. So once this is done, we'll move on to the nephrectomy part, which is done as usual. Bleeding reduces very, very significantly once artery is clamped. So this is the upper pole of the tumor separating from the liver on the lateral aspect. So the tumor is now here on the lateral border IVC. Keep dissecting. This is standard nephrectomy as we do. The ureter is divided. And ultimately the kidney. The video is hanging a little bit. So what is done is you can either apply a clamp and remove the specimen, or just take a tie over the thrombus and the IVC and just give it to the CTVS team. So once the CTVS team takes over, the one has to inspect because heparin has to be given before the patient is put on bypass machine. The hemostasis has to be very, very accurate. And once the hemostasis is confirmed, you start opening the chest. Sternotomy is to be done. Then pericardium would be opened. Now you can see the right atrium here, the appendage of the right atrium. And the one cannula would be put in the IVC below the level of thrombus, another cannula in the SVC, and another cannula in the aorta to maintain the flows. Once that is achieved, once the patient reaches the 18-degree temperature, cardiac arrest is made. Then the atrium would be opened, and then you mobilize the thrombus both from above and below. Some part of it generally is removed from the heart, and the part of it would be removed from below. So generally, one is not able to take out such thrombi which are distending the IVC in toto. So generally, this is a piecemeal removal, but one can put the fingers from above and fingers from below also, and even Foley's catheters can be placed from below with a distended balloon to pull out the entire thrombus like we do for a Fogarty catheter. And then complete flushing is done. Even gauge piece can be used to flush out the very small sticking tumor thrombi from above and below. This gauge piece can be used. And then once you are sure that the entire thing is removed, there is a echo, transesophageal echo that is to be placed, and that also confirms that the entire thrombus has been removed. Once that is done, the venotomy is closed from below, and the simultaneously one team can close the atrium. So this entire removal of the thrombus happens in usually within 20-25 minutes only. On cardiopulmonary bypass, we can go even up to 40 minutes, but generally 20 minutes is considered as the safe limit. If more than that is required, generally the patient is brought up to a higher temperature, 25 degree, it stabilized for some time and then recooled again as a second cycle. So here the heart is being closed. Once this is done, this would be a patient is gradually gradually warmed up patient, and then once the warmth is established up to 35 degree, then the patient is closed and can be shifted to the ICU for the postoperative care. Now, a word about the distal bland thrombus. So what happens in patients who have bland thrombus below, even if you remove the bland thrombus completely, what happens is these patients tend to form the thrombus again, and the bland thrombi in large vessels like IVC can cause pulmonary embolism very quickly. So therefore, it is much more safer to actually tie the IVC if there is a bland thrombus. You remove the thrombus, but then tie the IVC or the ligate the IVC in these cases. IVC filter generally do not help in such a situation because already this is a post-operative situation, and it would be very difficult to place the IVC filter retrogradely from below upwards. And coagulation also we do not want for a longer duration. But in patients who have a partially patent IVC where the collaterals are not there, where the thrombus, you can see that the flow is happening around the thrombus in the pre-op setting, then the collaterals do not form as such. So in those settings, we cannot block the IVC blood flow in the infrahepatic IVC completely, because it will take some time for the collaterals to develop. And till that time, there is going to be very, very significant edema of the lower half of the body. So therefore, consider ligating the whole of IVC only in patients where there are significant collaterals already formed and the IVC was completely blocked. So I think coming towards the end. So this is the same thing. I think I'll skip this because sometimes the tumor thrombus splits and actually goes into the pulmonary arteries from the right atrium. Embolus kind of splits from the main tumor thrombus and goes into the right ventricle, and then sits into the pulmonary arteries. Now, these pulmonary arteries separate tumor emboli should not be considered as metastasis. Even they can be removed in the same sitting, and they generally have the same prognosis as for this level 3C thrombi. Sometimes when the venous wall is involved, we can replace it either as a patch graft or as a tube graft. This Dacron graft or a PTFE graft can be used, whatever is available with the CTPS guys. And generally this is done by the CTVS. But once the whole IVC is to be removed, one has to be careful about the opposite renal vein. If there are not enough collaterals on the opposite side, then it is better to make an anastomosis of the opposite renal vein also into the same tube graft. So these are some of our papers, and now if there are questions, I would be happy to answer. Thank you.
Yeah, excellent presentation, Rishi.
Thank you, sir.
We heard a lot of new things. One question: we heard that some systemic therapies can be used to bring down or shrink the thrombus so that it can be downstaged. Any
Yes.
experience about that?
I would not say good experience. I have only anecdotal 1 or 2 cases who were already started and then referred to us. But generally what happens is they are supposed to work only in cases where the thrombus is very well vascularized. Probably there you may reduce the size of the thrombus to some extent. But in the process, what happens is they would require good 3-4 months of therapy before this can even happen. And you are putting the patient at risk of metastasis and embolus as well in that interim period. So therefore, we do not use that. And ultimately, even if the thrombus shrinks to some extent, the surgery that is going to be required is it's not that a level 3B thrombus is going to become level 1 or 2. It may just be a 1 centimeter, 2 centimeter shrinkage, which may not be of clinical usefulness at all.
So it's not a very advisable thing to.
No, we do not do that.
Right.
So there's one question in the chat box from Dr. S.K. Tiwari. What are your advice to young urologists regarding level 2 and above thrombus when they are starting off radical nephrectomy in such situations? Any tips and tricks, sir?
The most important tip is do not try to mobilize the kidneys as for standard nephrectomy, particularly when you see collaterals on CT and MRI. Read that CT and MRI very carefully. If there are collaterals formed, even if you are not able to see collateral, just see whether the IVC is distended and stretched out. In those scenarios, there would be some collaterals. So go with the artery first technique. On the right, for the early phases of your career, choose the right side tumors. Left side tumors are more difficult when the thrombus is there, because reaching the artery by itself is a huge task without causing significant blood loss. So therefore, choose right side tumors first, level 2 and below, and use the artery first approach. So if you go by these 2-3 steps, then most of the times you would be able to manage the cases perfect.
Yes, sir. So one more question in the chat box. Is there any specific advice regarding tumor or thrombus handling before clamping to reduce the risk of embolism?
You can always isolate the upper IVC first and keep it looped, but you cannot clamp it. Just keep it a little bit looped in a vessel loop, and then keep the artery a little bit tighter, partially occluded kind of a thing, so that the venous flow is also not occluded. And if some big it will not prevent small embolus, but at least a large embolus would be prevented if you dissect the upper IVC first and keep a loop over it.
Thank you, sir. So one more question. It has come in the chat box. Does preoperative angioembolization help in any way in these cases?
Not in right side, because for the right side tumors, one is almost always able to access the right renal artery on the right border of aorta in the anti-aorta cava groove. But for the left side, yes, in some cases where the renal vein is very extensively distended and there are significant collaterals, in those cases, putting in a temporary glue for immediately, either in the previous evening or early morning. You can put in a glue so that you are able to save some blood loss for the patient till the time you are able to control the artery. So yes, in left side tumors where the renal vein is very distended, their angioembolization still has a role.
Thank you, sir. Thank you.
Thank you. Thank you, Rishi sir. Great thanks from us, from Bengal Urological Society. I have a question, sir.
Thank you.
In case you think about a thrombus and in the operatively you see the vein is invaded, any other tips and tricks to manage that?
See, renal vein invasion usually happens at the renal vein ostium. Most of the times, it would be very rare for venous wall infiltration to happen over an extended area. Once that happens, that reduces the prognosis also. So in those scenarios where the venous wall infiltration is very extensive, then we may not consider removing the entire IVC, because you will have to replace that IVC. There is going to be morbidity of that replacement itself, and the survival of such a patient is generally not going to be beyond 1.5 years. Although if you can get away with just 4-5 centimeter graft tube, that may be enough. Beyond that, do not try to remove the entire length of intra-abdominal IVC. Those kind of heroic maneuvers are not recommended. Because generally what happens is if there is venous wall infiltration, that happens, extensive venous wall infiltration, that happens in sarcomatoid and rhabdoid kind of tumors. Clear cell RCCs generally do not have that extensive venous wall infiltration most of the times.
So, any more questions before we can round up the session?
For PG specifically, whenever there is going to be a RCC case and there is even a level 1 thrombus, the discussion may boil around all these surgical steps and how you should interpret those steps beforehand during your preoperative evaluation. So that is important. So knowing these steps, what is to be done and how to assess those findings in the CT itself. If you can comment on all those findings, then that is going to fetch you marks.
Yes.
So thank you, Dr. Rishi. I believe you can wrap up, Jose.
Yes, sir. Yes, sir. Thank you, sir. Thank you, Dr. Nayyar, for a very enlightening session, enlightening discussion on this very important topic of discussion. So thank you, everybody, for participating in this session. So
Just a minute. Let me thank you.
yes, sir.
Thank you, sir. Thank you
Thank you, sir.
for
Thank you.
all the thanks from US. And this session is obviously going to help our members a lot. And we wish
Thank you, sir. Thank you, Dr. Mandal.
Thank you, sir. Thank you, sir. Good night, sir.
Thank you.